I think the difficulty that I'm having is that um, it's hard to know what the space is. And let me be a little bit more clear. So when we're trying to focus on a diagnostic problem, we're trying to clarify two things. What is the nature of that problem? And that's what we call the diagnostic space. An example would be chest pain or abdominal pain or anemia. And the other dimension on the XY axis is the time course. And here the space is so diffuse, it's hard to know what it is. But more helpful is the presence of pretty much a lot of clarity to a certain degree on the time axis. The time axis here is that it seems that this person was functional enough to be on a ladder 5 days ago. So presumably, although not definitively, was okay then and has been falling off the ladder, both literally and metaphorically in the last 5 days. And so it's hard to know what to represent the space that you're in. And so I think this is a great, great, great place to actually make no progress. And I mean that. You should be careful not to commit and say this is a diffuse pain problem, or this is a difficulty ambulating problem, or this is a not feeling well problem. You're on the scent for something that you haven't quite definitively picked up yet. So there's a lead somewhere there. This is an acute syndrome, but a syndrome of what is unclear to me. And I think the mistake to make is to commit to the nature of the syndrome. So unlike what we usually do in 30-minute VMR, where we have our foot on the gas going full speed, my advice here, slow down, get the data you always get in everybody, which is a comprehensive history, exam, and background. And if then you don't have clarity, you need more data. If then you start to coalesce to a syndrome, you might be more focused. So here, do the exact opposite and slow down. That would be my advice. But I wouldn't be surprised if Charmaine has picked up a scent more specific than mine. So I'll pass the mic to her.
Nope. The only thing that I would add that if it's just like I found this approach really, really helpful. And like Gurpreet Dhaliwal, who is incredible, taught me this. When I was like running morning reports, fall would come up often. And I was like, and it's so broad. And I don't have an approach to it. Like, what do you do when your like chief complaint is fall? Like, where do you even start? And he just like kind of simply put is like, fall is like opposite of standing and walking. So you have to think about what makes you stand and walk. So you need your cardiovascular system, you need your neural axis, your MSK, and the environment factors that contribute. So those 4 big things to think about, and that I found very, very helpful to help frame it. But can't wait to hear more, Jack.
Right. So in terms of the other elements of the history, it was difficult to sort of get a clear story, but I think the space and the time that you all had mentioned is spot on. He had a really difficult time articulating exactly what led to the fall. Because basically, like, I was sort of doing some work on a ladder, was reaching up to grab some things, and then the next thing I remember, I was on the floor. Since then, I've been in so much pain. But as we talk to him more, it sounds like he also has been feeling sort of generally not well over the last maybe like 3 to 6 weeks. He has a history of a left TKA from about 4 years ago, and his knee pain has been worsening like over the last 4 to 6 weeks. He's also felt increasing fatigue and malaise, and then also noted this sort of long-standing history of some lower urinary tract symptoms, sort of difficulty voiding, a stuttering stream, and he's been having increasing episodes of nocturia as well. So between those two things of like the knee pain worsening, the nocturia being a problem, he was like, I just feel like I haven't quite been myself. And then eventually this fall happened. In terms of the other elements of his past medical history, he has a history of alcohol use disorder. He consumes about a pint of vodka every day and has been continuing that over the time frame leading up to this. Also has a history of untreated Hep C and hypertension. And as I mentioned, he had the history of the left TKA. He also has a history of a right hip arthroplasty as well. In terms of the meds that he was taking, he is on, he takes losartan, as well as a PPI as an outpatient, but otherwise not a significant medical history or not a significant medication list. And then in terms of family history, it was unremarkable. Social history, I won't disclose a ton of details, but we'll just say that he lives locally in the San Francisco Bay Area and has no other significant health-related behaviors other than the alcohol use that we mentioned, and then no known allergies. And then in terms of the exam, so his initial vitals, he had a temp of like 100.1 in the ER. He was tachycardic to the 110s, had a blood pressure of around 130s over 70s. He was satting normally on room air and had a respiratory rate of around 22. And then in terms of his exam, he was like appeared uncomfortable in bed. He was tachycardic. He had a systolic ejection murmur at the left upper sternal border. Looked like that had been noted previously on some prior notes that we saw. His lungs were clear. He had a normal work of breathing. Abdomen was diffusely tender to palpation without rebound or guarding. His left knee was warm and swollen. He was able to passively and actively range it, but it was painful to do so. And he had sort of like normal range of motion, but it was quite uncomfortable for him. His right knee exam was normal. And then in terms of his neuro exam, he was alert and oriented ×2, but had no focal motor or sensory deficits. And he was able to walk, but it was uncomfortable because of the knee pain, as well as because of some other pain that he had after the fall. I'll stop there.
So much information. Thank you so much, Jack. So I think I'm just going to be true to the clinical reasoning exercise and just go through the rest of the HBI and past medical history as if I was admitting this patient, and then leave the rest to RG to distill. So this is not too uncommon of patients that get admitted to our services, right? Like the history is a little bit vague, and then there are like few complaints, and the question is like, are they all related to each other, or do we have to entertain different hypotheses? And I think it's fair to do both. So this is a gentleman who is coming in after a fall 5 days ago, but it seems like his symptomatology started about a few weeks prior to that. Kind of a few things to grasp on is this knee pain that he's having, and he has having increasing urinary retention and nocturia. Usually in the patient population that I care about, with mostly older men, BPH is the most common cause that you see for urinary retention and nocturia. Things that you want to make sure people don't have are urinary tract infections. And urinary tract infection is an infection in any part of the system, right? Like from urethritis to prostatitis, cystitis, you get the idea. And the other thing that you want to think about is like, hey, if there's any spinal cord pathology that can lead to retention or incontinence as well, and someone who's coming in with difficulty ambulating is another threat to investigate. In terms of like the left knee, one thing that from the past history that it jumps out to me is someone who has a hip replacement surgery, and he's 60 years old. He's quite young, relatively speaking. So if that surgery was years ago, then, what the etiology of that is? A tear in, is this excessive use, or is it, a pathology there that could be quite systematic. And the other thing that is in the history that is informant is alcohol, right? Alcohol as a toxin can lead to like nutritional deficiencies from thiamine that we can see with imbalance from like it can affect the nerves itself with like peripheral neuropathies, and again, like effects of alcohol anywhere in the bone as well. So that's something to consider. And the knee pain itself, kind of think about like if this is an isolated monoarthritis, then you want to think more about infections. You want to think more about trauma potentially. And I will let RJ layer on the exam after that. So those are the things that had jumped out to me. RJ, what are your thoughts?
I absolutely love it. I will rapidly move through analyzing the exam, and I'll tell you one key tenet. The older you are, the colder you are. When you are sick in less than 1 and you have an inflammation, you can mount a fever to 105. But the older you are, the colder you are. And so your baseline temperature drops and drops and drops. And so a fever of 100.1 in a patient who is 60 violates the older you are, the colder you are, and means that it is signal. This patient has a fever, and the question is, what is the initial infection? And the exam gives plenty of places to ponder: the abdomen and the knee. The only good thing about a prosthetic knee in terms of what the differential diagnosis is it's very unusual for crystalline diseases to affect prosthetic knees. That's because the synovium is scraped out and it's pure metal. And so the key question is, does this patient have septic arthritis as a cause of a swollen knee, or do they have mechanical dehiscence as a result of the fall? And the pain of the abdomen is abnormal and should be a focus that the laboratory data will shed light on. But again, this patient is probably infected based on the fever and those 2 localizing symptoms. But we have to remain with 1 foot in 2 different doors. And here are the 2 doors. Probably have my thing ready to share because I ruin the dramatic effect when there's such a delay to the doors. So keep your feet in midair, my friends, and we're going to slip 1 foot into the cause of the fall. And the cause of the found down or fall may be whatever, you have some condition that causes it, and we have to have another in the consequence. Okay, why did this person fall? Could they have a knee infection? But we also have to remember to stay open to the consequence. This phenomenon is best described in the trauma literature, where we talk about distracting injuries, where somebody has something so severe somewhere, like a swollen, infected knee, that we forget that they could have something else as well. So cause, consequence, why he fell, fever, the swollen knee, done. But has there been a consequence to it? And I think we have to remain open to that possibility. All right, and I'll hand it back to the OG master presenter, Dr. Jack Penner, who, by the way, for those of you who don't know, because VMR has been going on forever, Jack is basically the first ever case presenter on VMR, transitioned to leader of VMR for a very, very long time, and now is revisiting his roots. I think this is the first time you presented in a long time. Is that right?
Long time. It's super fun.
Yep. Alrighty, back to you, my friend.
Well, I'm also now the most recent person to blush on VMR. So we will go ahead and go through the clinical data. So initial white count was 13. It was PMN predominant. Had a hemoglobin of 6.7. Platelet count of 18. Metabolic panel notable for a sodium of 137, a potassium of 3.3, a bicarb of 16, a BUN of 104, and then a creatinine of 2.61. Lactate was elevated at around 2.7. AST was high, around 136. ALT was in the 80s. Alk Phos and T-Billy were normal. Initial imaging that we had included a clear chest X-ray, unremarkable CT abdomen and pelvis, Knee x-rays show no signs of periprosthetic fracture. Then we got an arthrocentesis of the left knee. That had 41,000 white cells, 80% PMNs, no organisms seen on the gram stain. Had a UA that was notable for pyuria. And I will say that the urine culture for that ultimately came back as showing E. fecalis and E. coli. And then blood cultures the morning after admission also came back 2 out of 2 positive for E. fecalis.
Okay, I'm just going to talk about the CBC and leave the rest of the data for Charmaine to analyze. But I need a favor from you. Okay. One, medical disclaimer: do not participate in this exercise if you are unable to hold your breath for 10 seconds. Why? Because when you see thrombocytopenia, I need you to hold your breath until you've, yeah, Charmaine, do it. Oh, I should talk really quickly. You need to make sure there's no schistocytes and heparin. Okay, you can breathe. Hold your breath until you've ruled out schistocytes and heparin. Why? Because you need to know faster than you need to breathe if the patient has heparin on board or has schistocytes. Those are 2 incredibly life-threatening diagnoses where your patient might have a devastating consequence from thrombocytopenia well before you have time to think about it. So you need to have this reflex. Schistose, heparin, breathe. Okay? Now, heparin, nada, schistose, maybe. We'll see. Alrighty, Charmaine, I'll pass the mic to you for the rest of this.
Can I be honest? I don't like Ephesaurus bacteremia. Just never good things happen with that bug, to be honest. I just don't like it. I think when we were initially thinking about like infections, as Robbie beautifully mentioned that, and now we have a bug. And the question is like, hey, we have possible like urinary source. We're worried about that knee, and now we have it in the blood. So what to do? So when we worry about disseminated infections, Ephesaurus endocarditis is something to consider. So definitely need to get an echo and evaluate for that, because it changes your antibiotic regimen if there is endocarditis involvement. And in terms of like an arthrocentesis with that left knee, call ortho. I try, if there's a concern for a septic prosthetic joint, I always call the surgeons to do a washout. Again, like prosthetic, I think sticky bugs, like sticky things, and prosthetic is one thing. And he also has a left hip that should be evaluated as well. So in terms of the bacteremia, getting in the right antibiotic, as Robbie mentioned, investigate that anemia a little bit more, echocardiogram, and that's call the surgeons is my plan for this patient. Jack, can't wait to hear what you all did.
Sounds good. So this will be the last aliquot, and then the final diagnosis will come after that. So we sort of it did exactly as you said, Charmaine. I can give the results of the blood smear showed no schistocytes. The fibrinogen level was normal. We reached out to heme. They did a bone marrow biopsy that was unremarkable, and his cytopenia has improved as we ultimately sort of throughout the course of his illness and without consuming alcohol. We got the ortho saw him and took him for a washout and a liner exchange. The cultures from the arthrocentesis eventually came back also showing E. fecalis. And then he had a TTE that showed no signs of a vegetation and moderate aortic regurgitation, no prior echo to base that off of from previous. And that is where I think we will stop. And then I can go ahead and give the final diagnosis after that.
Oh, okay. I can give my thoughts and then have RJ give his thoughts too. I am still worried about endocarditis. So I think that is a conversation that tends to have in real world between infectious diseases, cards, and us, like as primary teams to think about like, okay, TTE is negative. Oh, things to worry about. If you have a prosthetic valve, then TTE is not as sensitive. But thankfully he doesn't. How I think about echoes is that it is still quite subjective, right? Somebody does an imaging and another person reads it. So it's not perfect study. And so I think it's worth thinking about TEE in these patients, or PET scans at times can also be very valuable in showing a hotbed of an infection. The other things to think about, making sure to look at ECGs and thinking about like aortic root abscesses to look at that PR interval. I'm still a little worried about endocarditis. I think treating the bacteremia for now is a solid plan. RG, what are your thoughts?
I think that's absolutely superb. And I'm going to play a little game with you called Did You Know? That's the title of said game. Did you know that MRIs can miss strokes? In fact, about 5 to 10% of posterior fossa strokes are missed on MRI in the first 24 hours. Did you know? Did you know that MRIs can miss strokes? Did you know that echoes can miss endocarditis? Yes, we'll talk about that. Did you know that cardiac cath, can miss the myocardial infarction? Yes, they can. Did you know that a surgeon can miss necrotizing fasciitis on a fasciotomy? Yes, they can. Did you know a surgeon can miss compartment syndrome with a fasciotomy? Yes, you can. We have gotten so used to this illusion that there is something as a perfect test in medicine. And there are things that come close, like MRIs for strokes and CATs for heart attacks and echoes for endocarditis, but they're not perfect. And here's the case for endocarditis. The first is an error that is made all the time, and I'm probably the best at it, making this mistake. I did it already today. When Jack said, hey, we've already heard this murmur before, I was like, oh, cool, it's about it. Don't we make this mistake all the time? I even like work on not making this mistake, and I make it all the time. So when a patient has an existing murmur, they have an existing valvular disease, they probably have endocarditis. What's the other case for it? You have septic arthritis. Do you know the rate of endocarditis along with septic arthritis is fairly high? I don't know the exact numbers, but it's high. What's another clue? You have potentially a microangiopathic hemolytic anemia and thrombocytopenia. You have a hemoglobin of 6.7 and platelets of 18 without a clear cause. Endocarditis, a notorious one. And most importantly, you have eficalis. And as Charmaine alluded to, eficalis is notorious for causing endocarditis. But even more telling, you don't just have a systolic ejection murmur related valve disease. You have regurgitation. That valve's not working in the opposite direction we expect it to be. So this is a scenario where even though the echo says no endocarditis, the patient is now literally screaming it with baseline valve disease, with a fever, with septic arthritis, with microangiopathic hemolytic anemia, and a bug that says it. So I think you should probably treat for the duration of endocarditis no matter what. But then another question. We know where this bug went. It went to the joint and it went to the heart. Key question is, where did it come from? And it probably came from the urinary tract, but you have to make sure that there isn't an alternate source like the GI tract, and the CT abdomen pelvis is pretty good, but occult luminal disease like a colon carcinoma, as Charmaine will tell you from an incredible case that she presented on a podcast to one and only Gurpreet Dhaliwal, enterococcus can be seeded from a colonic tumor. So that anemia, especially if it's not completely normalized, might cause you to reconsider. So a lot of threats to this case, but I think the key learning is tests in medicine are pretty good, but they're not perfect. And if an MRI can miss a stroke, then an echo can miss endocarditis, I promise. All right, JP, Mike, to you.
All right, I will take us home very quickly here. You all are spot on. So the TEE ended up being done, and that showed a whopping 0.8 centimeter vegetation on the aortic valve. in the interval time frame between when the TTE was done and the TEE was done, which was over the course of essentially like a Thursday to a Tuesday, that moderate AR had worsened to severe AR. So the ultimate diagnosis was aortic valve endocarditis from E. fecalis. The question of sort of where this came from, I think the jury was still out. We had one formulation was that it was a polymicrobial urinary tract infection in the setting of these sort of lower urinary tract symptoms that had been brewing for some time. The other possibility was that it came from the GI tract and then also unfortunately had an E. coli UTI. So one formulation was this was basically a bimicrobial ascending UTI or a E. coli ascending UTI and then a descending UTI from the bacteremia with the E. fecalis. He ultimately has undergone aortic valve replacement and then is awaiting the workup for the GI causes. But I think exactly as you all highlighted, one of the things that I learned from this case and a case earlier in the year from the one and only Dan Minter is how limited the sensitivity of TTE is in the setting of E. fecalis endocarditis. So it's insensitive across the board, but particularly so for enterococcal endocarditis. But absolutely phenomenal job. And you all nailed this one. I will stop there so that we have time for reflection and also what is going to be epic teaching from Sammy.
Thank you, Jack. I feel like, bacteremia and endocarditis, like really great medicine cases to discuss because you never have to, there's always another why to ask. Is like, okay, where did it go? Where did it come from? Why is this patient bacteremic? Why? It's a favorite question in medicine. And I just like it always like humbles me how much devastation an infection can cause. This guy hasn't been feeling good for a while, but pretty functional, now having to undergo a valve replacement therapy. It's a lot. So thank you for presenting and great case to discuss. RG, any thoughts?
No, I completely agree with that reflection. I think we often think infection, okay, not cancer or autoimmunity, but especially when an infection makes it on the inside of your body all the way this far, it's usually not good news. Yeah. Alrighty, Sammy, take us home, please.
Wow, what a great case. Thank you so much, Jack. I learned a lot and also great discussion by Charmaine and Ravi, and the chat was also very great. So thank you all so much for participating today. I will just go over some quick teaching points because we are already advanced in time. There are two dimensions for representing a problem, the space and the time. And if we only have a vague clinical syndrome or history, we should always step back, slow down, and try to get more information and then proceed. A simple approach to tendency to fall is think as the opposite of standing. What do you need for standing? You need cardiovascular system to be working, your neurologic axis, your musculoskeletal system, and also can be contributed by environmental factors, as Charmaine taught us. When we see urinary retention, we should always think about BPH, but also consider urinary tract infections, but also spinal cord disease. Another very important teaching point is that the older the colder, so that we shouldn't disregard inflammation in the absence of fever in older patients. This is very important in comparison to children who always mount a larger inflammatory response with high fevers. Ravi taught us that when we see thrombocytopenia plus anemia, we should always hold our breath and exclude emergencies and check schistocytes and heparin exposures. And after excluding that, we should continue breathing and get a more advanced workup. When we have bacteremia, always get an echo and check prosthetic implants. Sticky bugs like sticky things, because it also changes the medical management and the duration of antibiotics. When we have a high index of suspicion for infectious endocarditis, but an unremarkable TTE, we should always get an TEE, which has a higher sensitivity for vegetations, and also ECG, which is also a great pearl. When we see PR or PQ prolongation, this could make us more think of a paravalvular abscess, which can be seen in infectious endocarditis. And the most important teaching point, I think, for today is then that when we have a high pretest probability for a certain disease, but a negative diagnostic test, which should normally diagnose the disease, we shouldn't disregard it. because it doesn't alter our post-test probability that much and is still the most likely diagnosis, as we saw in this case. And yeah, I think it was a very educational case, and thank you all so much for participating, and have a great day.
Sammy, you're amazing. Thank you all for joining us. This is always a highlight of the week for me. We'll see you tomorrow.